Well, I did the same.
and without clinical practice. So the question is whether we can retain responses if we shorten treatment regimens for those patients who respond early during the treatment. So I was thinking, what is our main goal in first-line treatment of B-cell malignancies? And it's probably we want to prolong overall survival for all of our patients. So how can we achieve this? By having better diagnosis, more precise prognostic factors, more effective treatment, and also we are being helped with more sensitive methods to evaluate response. And in some of these B-cell malignancies, this is helping us to choose treatment. So in this way, we can choose what is the best treatment for our patients, trying to balance between efficacy and toxicity. For many years, we have chosen treatment according to predictors of response to treatment, but maybe we can move forward to treatment adapted to response. For the last decade, we have known about the importance of interim PET scan, both for progression-free survival and overall survival, in Hodgkin disease and also in non-Hodgkin lymphoma, dividing patients maybe in two big categories, those who have persistent positive PET or who have no metabolic lesions in final or interim PET scan. So how can we incorporate this in our everyday clinical practice? By treatment adapted to response with effective induction treatment and sensitive methods to evaluate response. So can we select patients who achieve a quick response in whom further therapy will add no beneficial survival or no survival benefit? And there are many different cooperative groups addressing these questions in different histologies. These are just some examples. This is the Liza and Goelam's group doing R-CHOP with or without radiotherapy in non-bulky, limited, early-stage diffuse large B-cell lymphoma. And the question that they are addressing is whether after 4 cycles of R-CHOP, patients who are PET negative really need to go on to further therapy. So they're randomizing patients which are PET negative after 4 R-CHOP, and with a low IPI in watch and wait or consolidate with radiotherapy. And I will only deal with this part to show you that in this case, the addition of more therapy added no advantage in both in event-free survival and overall survival. So the conclusion is that we need no more therapy after 4 cycles of R-CHOP. So the question is a negative PET-CT after 4 cycles of R-CHOP a sufficient powerful method to stop therapy in all our patients? Can we address this question in future clinical trials? And there are other cooperative groups trying to lower down or to reduce or abbreviate induction therapy. This is the clinical trial. This group used to use 6 cycles of chemotherapy before autologous stem cell transplantation, and they're reducing it in this clinical trial to only 4 cycles of RDHAP, and to go on to further therapy only in patients who have not achieved a good enough response to go on to autologous stem cell transplantation. So maybe a good proportion of our patients can have less induction therapy for mantle cell lymphoma. I'm sorry, this is for mantle cell lymphoma. We have our own experience with our cooperative group in Argentina regarding PET-adapted therapy after 3 cycles of AVVD for all stages of Hodgkin lymphoma. Many different clinical trials have been published trying to reduce therapy for early stage Hodgkin lymphoma, and the difference with our trial is that we are addressing all stages with the same treatment. So all patients receive 3 cycles of AVVD, and if PET scan is negative, they are considered in complete remission, and we stop therapy. We have 365 patients evaluated. 70% of these patients were PET negative, and they will only continue with follow-up. And this is a curve for those patients who are PET negative. And then in the top 2 curves, we see the proportion of patients who are PET negative. In the blue line, patients with advanced stage 2B, 3, or 4, who only received 3 cycles of AVVD. And in the orange line, patients with localized stage and only 3 cycles of AVVD. So we can see that the curves have overimposed, and the progression-free survival at 4 years is almost 90%. And this is with a median follow-up of more than 5 years. So for Hodgkin disease, these are a long follow-up. So regarding these results, the question is, are we ready to abandon traditional prognostic factors in patients with all stages of Hodgkin disease and to adapt therapy to early PET-CT? And what about CLL? Are we ready to stop therapy in patients who achieve an early complete remission with a negative MRD? We talked today about not using MRD to follow on and keep on going with treatment, but my question was, maybe can we use it to stop treatment earlier for some patients? So we know about the importance of MRD negativity, and this has been shown over and over in many different clinical trials. Regardless the treatment they received, the importance of achieving an MRD negative complete remission. So we're not talking about treatment, we're talking about results of treatment. And we know this is important not only for progression-free survival, but also for overall survival. This is also a very interesting slide, which is given by Dr. Halleck. And we can see that patients with complete remission in MRD, and that is the blue line, have a almost 69 months progression-free survival. Patients who are considered to be in complete remission, but with a positive MRD, have 44 months. And what I find interesting here is that patients that we consider to be in partial remission but have a negative MRD have the same progression-free survival as those with complete remission and negative MRD. So this is the great importance of having a negative MRD. And this has been shown earlier today, but about the two top curves are patients who achieve negative MRD with 3 or 6 cycles, showing no difference. So here the importance is not how many cycles or what chemotherapy they received, but if they achieved negative MRD. So we have our own experience. This is the experience of our own center, where we abbreviated regimen to only 4 cycles of FCR in physically fit patients with CLL who achieve an early complete remission with negative MRD after 4 cycles of FCR. So we stopped therapy after 4 cycles of FCR if patients were in MRD negative complete remission. And this is our results. This is with a median follow-up of 81 months. The progression-free survival is of 51% and 75 overall survival at 60 months. So these results are almost the same as those published with 6 cycles of FCR. So we think that stopping therapy in patients who achieve a negative MRD after 4 cycles of FCR is safe and induces durable remissions with a median progression-free survival of 65 months, not being reached the overall survival. So the conclusion of this trial, well, I just read the first one, and with this approach, patients are exposed to less chemotherapy and an excellent outcome. No late neutropenias were reported on evaluable patients. This data is comparable to the one published with 6 cycles, and we need larger randomized trials to confirm this data. So maybe the question about stopping therapy early, whether it's safe or not, I think that if having effective induction therapies and sensitive methods to evaluate response in patients with B-cell malignancies, are we ready to adapt therapy to response? Can treatments be abbreviated in those patients who achieve an early complete remission? Do all patients need the same number of cycles? Why are we giving 6 cycles to everyone? Isn't that an arbitrary number? Is 6 really better than 3 or 4? So are we ready are traditional prognostic factors still as powerful, or can we move forward to design clinical trials with treatments adapted to response therapy?
Thank you very much. Do you have any biological data on those patients? CLL went on the MRD negative?
No. At that time, when we started our clinical trial, we only did CD38.
Okay, so, and you don't store material?
Not for all patients, not routinely, no, unfortunately.
The issue of the cycles, I think, is extremely important. I mean, I think
I-
we're all familiar with the fact that sometimes the problem is that, I mean, it's the usual story. The approval is for 6 cycles because that was the design of the study. So in theory, we should do what the protocol says, but clearly toxicity is there. So many patients, in fact, get less.
Yes, and
Less
toxicity
number.
grows as you grow on cycles.
Yeah,
So
You
the
know,
more cycles you give, the worse are the toxicities.
and,
Johnny, what?
you know, in our history, again, one of the oldest histories is chemotherapy is breast cancer and adjuvant breast cancer, which originally was 2 years. Then they tried 1 year versus 2 years, and 1 year was just as good. Then 6 months versus 1 year, and 6 months was just as good. And then 3 months versus 6 months, and 3 months was just as good. Then they quit going down. But the question is really, how do we really get to, because you're exactly right, 6 is as arbitrary as anything out there. You know, 4 is usually it was just because of kind of half a year is where the 6 number usually came. So the question, how do we really know, and is MRD with chemotherapy the right measure? And again, and then which tumor types? Is it again in a CLL where, you know, you're not curing them, or if you are, you're looking for long-term remissions versus a DLBCL or a Hodgkin's, where the difference between, you know, cure and not is big, you know. And
You know,
that,
I mean, in theory, you should do a randomized study, which is totally unrealistic nowadays, obviously, but that's the only way of doing it. I mean, this is a lesson we learned with Hodgkin too, and we've been decreasing treatment, and with ALL in children. I mean, it's gone exactly the other way around, that we are giving much less treatment now than 30 years ago in kids, because we've overtreated many children, it's
Yes,
obvious.
if you remember Halleck, the first study, CLLH, let's say to use the double dose of rituximab,
Yeah,
and for 8 cycle
Yeah,
of
that's right.
FRC, and it was without reason, I think, because if the gold standard is to reach the MRD negativity or response, clinical and molecular response, if you reach with 4 cycle or with 6 cycle or 8 cycle, I don't think it is different.
I
But
think
it's important
Yeah.
to analyze the prognostic factor, because I don't know if in this group there are patients with a negative prognostic factor that failed
that's-
before.
So we started a trial in HIV large cell using short course EPOCH-R around 2002, and we published it about 4 years ago. And what we did was we did what you were doing, is that we gave them 2 cycles, because the standard, of course, is 6 for large cell. And then we did a FDG PET. And in our case, if their PET reduced by at least 75%, they simply got 1 more cycle. Even though it was a phase 2, the results of the patients, first off, 80% of patients only received 3 cycles. And the results in terms of EFS are and continue to be identical to what we got with 6. So I think there is no doubt that we need to be using more rational ways of looking at how much chemotherapy people need.
Also, because we're losing patients after FC. I mean, who wanted to comment?
Just to remind, if I'm not wrong, in this CLL8, around 25% of the patients didn't complete these 6 cycles.
Yes, and only 10% were over the age of 70. Yeah.
I certainly think this is an excellent direction our field should pay attention to. We do all this sophisticated next-gen sequencing, RNA expression, proteomics. We should direct some of the technology to detect minimal residual disease. If we have the best assay, we know when the disease is gone, when the disease is back. We can certainly tailor the therapy like you suggested. Thank you.
But that, yeah, totally agree. But it also goes back to the point that, I mean, some patients can respond and then progress 8 years later with disease, never eradicated. And that can be very good for many CLL patients. So again, it goes to categorizing which patients. Some with more aggressive need to go to eradication. Some others might be happily, let's say, contained in their disease.
And I think a little bit is, again, a lot of us have been around since a lot of the chemotherapy regimens and did the original, CHOP versus MACOP B and all that. And what's interesting is when when you're a hammer, the whole world's a nail. It's a little bit that thing is when we only had one chemotherapy regimen, we made sure we gave it the maximum because it really wasn't anything. Now the fact with where we're coming into between not just a signal transduction agent, potentially some of the immunotherapy approaches and others that may come, we actually have that potentially second way to approach, or second or third or fourth way to approach it. So again, limiting then the chemotherapy makes so much more sense now that even, if you lose a few people, you may be able to pick them up later if they're the late relapsers. So I think, again, it is the time now, we kind of say, we're away from chemotherapy, but I think it is the time now to really say, because I think everybody believes chemo's here to stay. It's not going to go away, but how should we use it more effective in this day and age? I think that's a question. And again, can we get by with 3 cycles of ABVD and reduce the risk of all the late complications in our Hodgkin's disease patients? That's a critical question now.
Sure.
I think the point is not to reduce chemotherapy, but the point is how we can choose a subset of patients who will do well with less chemotherapy, not reduce chemotherapy to everyone, but personalized therapy and try to choose those patients in which more chemotherapy will add no benefit, which is not the same.
And I think it's what we're starting to learn, putting the biology, incorporating not only
I am
the
sure
monitoring,
not
but
everyone needs the same amount of chemotherapy.
Absolutely.